This is the session of Women in Ophthalmology. So there are 6 speakers. Time is 12 minutes each. So we will finish within the time and you call one after another.
Perfect. So, good morning, everyone. Thank you for. Good morning, everyone. Thanks for getting here on time because the traffic in India is really quite impressive, I have to say. So we have a slight change of order because Dr. Ellie Preden needs to go to another session soon. So she's going to start off with trends in anti-VEGF treatment for DME. So real-world life experiences in combating retinal diseases is the theme of our session this morning.
Thank you, Abba Madam, Carmen, for inviting me in APAO WIO session. So the topic I'm going to speak is about trends in anti-VEGF in diabetic macular edema, which is it's rather difficult situation for us when it doesn't get treated. So this is my place with no financial disclosure and conflict of interest. As we all know, diabetic macular edema is the leading cause of moderate visual loss. Winkelson epidemiological study of diabetic retinopathy found that 14-year incidence of DME in type 1 diabetes to be 26%. And DCCT reported that 27% of type 1 develop DME within 9 years of onset. So what are the types of diabetic macular edema? One is clinically significant macular edema, retinal thickening within 500 micron of the center of the macula. So exudates within 500 micron of the center if associated with retinal thickening. And also third one is 1500 micron thickening or larger within 1 disc diameter of the center of the macula. So again, this is divided into central involved DME and central non-center involved DME. As you can see, this is the center involving DME when it within 1 millimeter of diameter, and when thickening is central involving is when it involves the central subfield zone, and non-center is that does not involve the center. The one below is clinical center involved, and upper one is non-center involved. So what is the pathophysiology of DME? There's the main two pathophysiology, that is the alteration of blood barrier and increased vascular permeability, especially when there is hypertension, hyperglycemia, and hyperdyslipidemia. These all act on the blood cells, retinal barrier, and that causes DME. The main factor for causing DME is vascular endothelial growth factor, which is the heparin binding dimeric glycoprotein, and in retina produced by vascular endothelial cells, RP cells, Muller cells, astrocytes, retinal neurons, and pericytes, and which is necessary for survival of retinal cells. There are different anti-VEGF, but especially for retina, it is the VEGF-A. So which acts through binding with VEGF GR1, 2, and 3. So what is the role of VEGF in DME? It increases the vascular permeability, and it also increases the inflammation, that ultimately leading to angiogenesis, that leakage, exudates, and swelling. So how does this pharmacological therapy in DME started? So early treatment, ETDRS study found that focal and grid laser photocoagulation was beneficial in treating DME, which leads to stable visual acuity and reduced retinal thickening. The DRCR-NET protocol A and B demonstrated that direct focal and grid laser photocoagulation is quite efficacious. But then there is also inability to improve the vision. So that's how the anti-VEGF emerged as alternating therapy for potentially improving vision. So there are different, as you can see in the market, there are different types of VEGF, anti-VEGF. Initially it started with pegaptinib, which comes as a Macugen, which binds to VEGF-165 isomer. Then comes the era of bevacizumab, or the Avastin, which is humanized monoclonal antibody. Then comes ranibizumab, which is Lucentis monoclonal antibody fragment, binds to VEGF-A, and the doses are given here. And then another thing is the aflibercept Eylea, which is the recombinant fusion protein, which is much superior to bevacizumab and ranibizumab. And there are newer anti-VEGF like brolucizumab, BOVU comes as BOVU, and it is the single chain antibody. It acts recombinant humanized monoclonal antibody VEGF inhibitor that binds to 3 major isomers. So it is again superior. It comes as a 6 milligram or 0.05 ml. Now the latest one is faricimab or Babysmo, which is the angiotensin-angioprotein 2 inhibitor that again causes suppression of endothelial cell proliferation, neovascularization, vascular permeability, and it comes as a 6 milligram in 0.05 ml. So now these are the anti-VEGF. They are again the latest anti-VEGF are also on the way. So how do we treat these DME? So there are studies when it compared with anti-VEGF versus laser in DME, that is in bevacizumab, that comes with the BOLT, which showed that a significant improvement in visual acuity in comparison to laser by bevacizumab group. Then there are certain other trial like Restore, Reveal, DRCR Net Protocol 1, which evaluated ranibizumab along with the laser. And in the Restore, it is the laser treatment versus ranibizumab alone, which is definitely is superior. And the reveal is ranibizumab laser versus with laser and the laser alone. And then the monotherapy or combined is again superior to laser treatment, standalone laser treatment. And DRCR Net Protocol 1 is ranibizumab, prompt laser, and another one is a deferred laser. Again, is the anti-VEGF is again superior to laser. Now, aflibercept studies Da Vinci and Vivid Vista. These are again compared with the laser treatment, and both showed that aflibercept is superior to laser photocoagulation. What is the dose and duration of VEGF in DME? Variation in DME. Bevacizumab, which shows that phase 2 DRCR Net Protocol H study demonstrated no meaningful or anatomical visual difference between 1.25 milligram to 2.5 milligram when it is administered 2 doses 6 weeks apart. Similarly, ranibizumab they compared with 0.3 to 0.5 milligram, again shows similar visual and that outcome. Aflibercept, it showed that it's a similar efficacy between when there are comparison between 2 doses. There is no difference between 2. Now, as of VEGF alone, when it doesn't get treated well, when it becomes a refractory, then we need to start think about inflammation, and when we use corticosteroid. There are certain studies like when there is a comparison between anti-VEGF and corticosteroid. DRCR Net Protocol 1 evaluated 0.5 milligram ranibizumab with 4 milligram triamcinolone. Which shows superior effect to grid and focal laser. But however, the corticosteroid had side effect like cataract and increase in IOP. And BUZX study showed that when it compared with bevacizumab 1.25 milligram with dexamethasone 0.7 milligram, there was no significant difference in vision gain in 2 years. Similarly, the DRCR Net Protocol T, when it compared with bevacizumab 1.25, ranibizumab 0.3, and with 0.2 milligram aflibercept, they showed that, of course, aflibercept showed greater visual improvement with more severe visual loss at baseline, but then there is no difference over 2 years. However, because in our area, because our country is, we still do not have DDA approved of aflibercept and ranibizumab. We still use bevacizumab because of the low cost. It is still an attractive option. Now then comes the refractory or persistent DME. What and why? So refractory, it is called when central thickness exceeds 2.5, especially for the micron stratus equivalent, and 300 with cirrus, despite monthly anti-VEGF treatment for at least 6 months. And now chronicity can cause chronic structural change in the retina. That's why it doesn't get treated with anti-VEGF alone. And in such instances, inflammatory pathways may be the dominant part than anti-VEGF driven pathways. So, and also the VEGF expression and sensitivity of retinal cells can vary from individual to individual. Then we switch over to anti-VEGF agents because of difference in molecular difference and pharmacological agents. However, this DRCR protocol T study shows that aflibercept is more effective, and REEF study showed that with, again, you know, this bevacizumab has incomplete response, then still ranibizumab, it has better effect than ranibizumab. Now the corticosteroid serve as the second-line agent in DMO management. DRCR-I protocol, triamcinolone plus laser achieves similar visual acuity as ranibizumab plus prompt or default laser group. And also this Zio et al. Showed that DMO refractory to 6 months, there's a single injection of dexamethasone will improve visual acuity. Now there is a combination of anti-VEGF and corticosteroid. It might have synergistic effect. So it will definitely have a better anatomical stabilization and improvement in visual acuity. And also combination of anti-VEGF and a laser therapy, which aims to capitalize on the immediate reduction of swelling or edema by anti-VEGF, and again by the then when you do the laser, that has a stronger laser stabilization. Now the newer brolucizumab, this is the single chain antibody. It is a lower molecular weight, and this Crystal and Kite trials show that brolucizumab 3 milligram, 6 milligram, it is equivalent. And it has found that over 100 weeks trial, brolucizumab 6 milligram doses up to 16 weeks showed notable visual acuity improvement compared to aflibercept. However, the side effects which is seen these days is the retinal vasculitis, retinal vascular occlusion, and intraocular inflammation were seen more with brolucizumab injection. Now this another one is faricizumab, which is the B antigen antibody that targets both angiopoietic 2 and VEGF-A, which is not inferior to aflibercept in other trials. Now, the three major strategies of anti-VEGF treatment: one is monthly treatment with fixed dose, and another is PRN when required, and another one is treat and extend. However, there are adverse effects of anti-VEGF like ocular conjunctival hemorrhage, increase in IOP, endophthalmitis, retinal tear and detachment, and it can cause systemic hypertension, thromboembolism, cardiac ischemia, internal organ bleeding, and delayed wound healing. Now, with this anti-VEGF, now there's a market has taken over by the biosimilars of anti-VEGF in DME, which is similar to existing innovative biologics, not necessarily the same development technique, and again, but these are comparable to pharmacokinetics. You know, there's immunogenicity, safety, and efficacy. And there are studies of these biosimilar and multisimilar. There are different biosimilars in the market. With this all, I would like to conclude my presentation for the anti-VEGF in DME. Thank you.
Thank you so much. I think we'll leave the questions, well, I think you need to rush off, right? So maybe we will, in the interest of time, we'll just move on to the next presentation.
Yeah, sure.
Yeah, thank you so much for
yeah,
this.
I'll be leaving after 10 minutes, yeah.
Okay, thank you. So, well, may we introduce the next speaker, Dr. Choi-Man Chan from Singapore, who's going to talk about new perspectives in inherited retinal dystrophies.
Good morning to everyone. Namaste. Thank you very much to the organizers for the kind invitation to speak today. Today I will be speaking on new perspectives in inherited retinal dystrophies, or what we commonly know as retinitis pigmentosa, or RP. And these new perspectives are actually based on advancements in genetics and therapeutics. I'll be touching on polygenic and modifier genes, non-coding variants, and this will lead to new approaches to gene therapy. Now, traditionally, we've always said IRDs are monogenic disorders. That means mutations in one single gene lead to this problem, the clinical phenotype. But now there is a thinking about polygenic contributions in IRDs. That means IRDs result from the combined effects of multiple genes and not just one gene, each contributing a very small effect. And this can explain why the clinical phenotype can vary widely among people with the same primary mutation. Now, what about modifier genes? Now, modifier genes do not cause disease directly, but they influence the severity, the progression, as well as the onset of the primary disorder. So I'm going to give you an example of a modifier gene. We all know RPGR. This causes X-linked retinitis pigmentosa, as well as X-linked cone rod dystrophy. Now, there is a mutation in RPGR-IP1L which affects the severity of these conditions. And how does it do so? It is a modifier. It interacts with RPGR in the ciliary transition zone of photoreceptors, and it's also linked to ciliopathies like Joubert syndrome and Meckel syndrome, which have overlying features with RPGR disorders. So what does this mean for us as a clinician is that when patients have the RPGR mutation as well as a mutation in RPGR-IP1L, this means this patient with earlier onset or more severe disease compared to someone who only has a mutation in RPGR. And this also means that when we do genetic testing, don't just stop when you find RPGR. You need to look for this other mutation in RPGR-IP1L that will help us guide to the patient and advise them about how severe the disease might be. Now, something else about coding mutations. Now, we always think that IRDs are linked to coding mutations in genes which are responsible for photoreceptor and retinal function. But now, non-coding variants, which occur in regions of DNA that do not directly code for proteins, can regulate gene activity. So I'll give you some examples. There are intronic variants, which disrupt splicing. So this creates or removes splice sites in the DNA, leading to abnormal mRNA and incorrect protein synthesis. That could be promoter variants, which affect transcription, as well as enhancer variants, which affect post-transcriptional regulation. So examples are CEP290. Now, mutations in CEP290 cause a very severe form of RP called Leber's congenital amaurosis 10. We now know that an intronic variant in intron 26 of CEP290 causes a cryptic splice site, leading to defective proteins. And it's very exciting because this can be treated with antisense oligonucleotide therapy, and I'll talk more about this later. Another one is USHA2A. This is one of the commonest variants that we have in our Singapore database. And this deep intronic mutations in USHA2A leads to exon skipping and therefore defective proteins. And the last example I have is PRPF31, which causes autosomal dominant RP. They have regulatory variants in the promoter region there, which affect gene expression. So all this talk, polygenic interactions, modifier genes, non-coding variants, what are the clinical and therapeutic implications for us as clinicians? Number one, it can actually help us solve cases where we don't find a causative mutation. I have so many cases where the patient has a clinical phenotype, but we can't find a gene. So these interactions here could explain it. And it also means, we always use panels, not next generation sequencing. That may not be good enough. We should think about whole genome sequencing as well as RNA sequencing to identify these variants. And this explains why even amongst the same family, same primary mutation, why the disease severity can be different. And what about how it affects therapeutics? There would be CRISPR-based gene editing, as well as antisense oligonucleotides, which can be used. So I'm going to jump right into that now. So the strategies we have for gene therapy is, traditionally, we all know, add the correct DNA to the cells of the patient. This is called gene augmentation. And the best example of this is Luxturna, okay, or RPE-associated LCA. The next one we can do is we can modify the patient's DNA. So this is gene editing, and a good example is CRISPR or Cas9. And the third example is at the RNA level with antisense oligonucleotides. So Luxturna, which I talked about, is very specific. RPE65, we just treat that mutation. How about a gene-agnostic approach? Okay, so that means it doesn't matter what the gene is. So Ocugen, the company, has come up with this product called OCU400, and this is an injection of an adeno-associated virus carrying the NR2E3. Now, what is NR2E3? It is a major retinal transcription factor involved in photoreceptor development. So by injecting it, it protects against photoreceptor damage. Now, there are mouse models that have proven this, and they have done phase 1-2 clinical trials where 16 out of 18 patients had ERG improvement. And now there's a phase 3 trial with 150 patients. So let's see what happens there. Now, genome editing actually targets DNA sequences, and the best example of this is CRISPR-Cas9. Now, this stands for clustered, regularly interspaced, short palindromic repeats, and it was such a revolutionary idea that the two scientists who discovered it won the Nobel Prize for this 3 years ago. So what we have here is you've got the guide RNA in orange, and it brings the Cas9, which is the endonuclease scissors, to the correct place in the DNA of the patient. And this inactivates the genes, and this is great for treating autosomal dominant gain-of-function mutations. For more precise editing of the genes, you can put in a DNA template, and this will correct the underlying gene defects. So a very good example is in CEP290-associated Leber's congenital amaurosis. Now, there is a deep intronic mutation, the IVS26, and this is in 60% or more of patients in the US and the EU have this mutation. So if you look on the left column, all right, this is the disease. There is this IVS26 there causing a pseudoexon, which is the red cross between exon 26 and 27. Now, this pseudoexon causes a premature stop codon, and we don't have the protein being produced. So Editas came up with the EDIT-101, which is an AAV vector containing 2 guide RNAs on both sides of the incorrect of the intronic mutation. It cuts it away, and by cleaving it, you get rid of the pseudoexon and leads to the production of the functional CEP290 protein. And this was it was published in New England Journal of Medicine, and this was the Brilliance CRISPR clinical trial. What about antisense oligonucleotides? These are very small, single-stranded RNA or DNA sequences, and it targets mRNA. So with the next step now, it alters the mRNA splicing, inhibits translation, and silences the gene. And therefore, it can be used for gain-of-function mutations. The advantage is it is an intravitreal form of delivery, something we're all very familiar with. And as a result, it is easy to use, but the disadvantage is you need repeat dosing. So here are the 2 modes of action. One is with gamma or RNA degradation. So here we have the ASO forming a duplex with the patient's mRNA, and the duplex is recognized by the RNase enzyme which cleaves the mRNA, and you don't have the abnormal protein formed. So one example is in rhodopsin P23H mutation. What about the other form of ASO with splice modulating? So here we have the ASO removes the pseudoexon, which lies between exon 3 and 4, and an example of this is in CEP290. This was published in Nature as well, and it's also very, very good for ABCA4, which we know is too large to fit within the AAV vector, so this is very elegant. The other example is how ASO removes the in-frame exons, causing truncating mutations, and therefore you have the normal protein formed, and this is used in USHA-2A. Now, the next step is stem cell regenerative medicine, because sometimes the IRD is too far advanced, so there are stem cell therapies. So again, Yamanaka and Gordon, they received a Nobel Prize for this technology, where they reversed mature cells all the way back to pluripotency by infusing it with Yamanaka factors. And we've tried this in macular degeneration. This was published in New England Journal, and they have put in autologous induced stem cell therapy for macular degeneration, but they're hoping to expand this to patients with IRDs. And optogenetics is also very exciting. This is published in Nature about 2 years ago, and this is repurposing other retinal cells, such as retinal ganglion cells, into new photoreceptors. And this is genotype agnostic, possibly disease agnostic, and is very promising for end-stage IRDs or acquired disease. And this is the proof of concept that was published. So this is all very well. Take a step back. You see, that sounds great, but that just sounds too far-fetched for me right now. It's not going to happen to my patients. So I'm going to give you my own patient an example. I saw her just 2 weeks ago, a 35-year-old Malay lady, newly married, with nyctalopia since her 20s. She has this phenotype. Now, always we think RP, you have to see spicules, but I wanted to show that actually you don't have to see spicules all the time, but the autofluorescence, very obvious changes on the white field. Her corresponding OCT shows disruption of the EZ layer. And her field's already like this when she's 35 years old. So she wants to have kids, but she's very worried. What's going to happen? So if you look at her, that's her with the arrow there. Her mother, and her father, how do I go up? Her mother and her uncle went blind from the same disease, but I've not seen them, so I'm not sure, but she told me they went blind. So what did I do? I sent her to the genetic counselor. We did genotyping, and she was found to have a pathogenic variant in the TOPORS gene, which causes autosomal dominant RP. Now, very interesting, she also had other genes. She was found to be a carrier of JB2 related hearing loss. She had variants of unknown significance in RP7, but the one causative variant was the TOPORS gene. So what did we do for her? We talked about pre-implantation genetic testing, which is a screening test performed on embryos created via IVF. So how does this work? First, we get the genetic diagnosis, we have that. Next, she has to go through IVF. And once you have the blastocyst at first week, we take some cells from that blastocyst, we analyze it to check whether they carry the mutation. And we only implant the mutation-free, unaffected embryos back into her womb. And that's, we may want to do prenatal testing with CVS or amniocentesis before the pregnancy is completed. Lastly, I just want to add, there's more to it. There's AI and deep learning, which might assist with IRD management and precision medicine. So this is a very, very exciting space to watch. So previously, all our patients are IRD. We always tell them there's not much hope, but I hope that with my talk, we get some new perspectives on how to manage our patients with IRDs. Thank you very much.
This is very exciting indeed. I think this is really the cutting edge of ophthalmology. I'm sure we all have lots of questions about this, so maybe we'll hopefully have a few minutes at the end to ask you questions. And let me introduce the next speaker at this point, from Dr. Leah Zaini, who's going to talk about the management of infectious endophthalmitis.
She's from which country?
Thank you, moderator, and thank you for the organizer for having me today. Today, I'm going to talk about the management of infectious endophthalmitis. Okay, I have no conflict of interest in this presentations, and we know that the endophthalmitis is a severe intraocular infection caused by bacteria or less commonly by fungi, and although relatively rare, endophthalmitis remains one of the most severe sight-threatening complications following cataract surgery. The improvement of surgical techniques, shorter operating time, smaller incision surgery, and the use of povidone iodines, also intracameral antibiotics at the end of surgery, make the incidence of endophthalmitis has decreasing in recent decades. This is proved by some study done, conducted between 1999 until 2020 that found there is the decrease in incidence of endophthalmitis in recent decades. So I'm gonna focusing about the post-cataract surgery endophthalmitis. So talking about the management of endophthalmitis, it means that talking about the endophthalmitis vitrectomy study, which is still the reference standard, evidence-based reference for management of endophthalmitis. And their recommendations is early vitrectomy in endophthalmitis was only beneficial in patients with vision of light perception or worse. However, we also know that the additional research is needed to complete this study, because the choice of treatment strategy based on the presenting visions may not be always reflected the severity of inflammations. There is widespread of availability for generation of fluoroquinolone, and the advances in vitreous surgery have become safer than before, and then EVS was not recruiting grossly infected eyes, and the systemic antibiotic use in EVS were only amikacin and ceftazidime. So these are the causes that current practice pattern deviates from the recommendation of EVS. But are there any other conditions that also need to be considered for the management of endophthalmitis? So we know that there is some study conducted between 1919 until 2020 that have a similar finding with what EVS finding. But let's take a look at my country, especially my province, in Aceh. Maybe we have a similar conditions with my province. I don't know, but we in Banda Aceh, in Aceh, with approximately 5 million people there, these retina and infection and immunology services only available in Banda Aceh, which is the capital city of Aceh. And Aceh is a province with most populations has financial limitations, limited hospital facilities, limited number of retina and infection services, and also limited availability of drugs. So we accepted referrals of endophthalmitis patients from all districts. And we have some problems with most patients have limited funds for medical treatment, and most patients do not have enough time to treat and regular control, and most patients come with very serious conditions. Maybe because of the time it takes from when the patient is referred until they arrive at our hospital is quite long. So this is our data from 2022 until 2024. As we can see here that most of our patients are post-cataract surgery endophthalmitis. And the more older the patient, the more frequent endophthalmitis patients. And for the comorbidities, most of the patients have no comorbidities, but diabetes mellitus is the most frequent comorbidities found in our patients. And for the spectrum of bacterial, we have a little bit different with other Western countries, maybe which Pseudomonas species is the most frequent bacterial isolates from the vitrios. So we also know that management of endophthalmitis protocols are to eradicate or control infections, managing the inflammation and supportive therapy. But I think we have the other point to be considered, like we have to do the fast management and use only facilities available at the hospital and consider the cost incurred by the patients. We can see this, most of our patients come with very severe visual query. 88% come with visual query with no light perception, and hand movement. And most of them cannot come to control regularly to our center. Only 69% of the patients can come to follow up until 1 month. So I think this is the most important reason why we have to choose the fast management for our patients. So we choose complete early vitrectomy study and endophthalmitis management study as additional reference to managing the inflammations. CVE recommended for doing complete early vitrectomy for fundus obscuring acute post-cataract endophthalmitis, and endophthalmitis management study use quantifiable inflammatory score instead of the presenting visions to allocate for surgery. And there is another study that have a similar result with what's HVE and EMS finding, like study by Bloom et al., Najafabadi et al., Tabatabai et al., and Feng et al. So surgery, as I said before, were our protocol to treat the severe endophthalmitis post-cataract surgery. Even EVS concluded that early vitrectomy in endophthalmitis was only beneficial in patients with vision of light perception or worse, but it seems to be no longer relevant because surgery can reduce the bacterial load, toxin, and inflammatory mediators, and then removal of vitreous as a growth medium of bacteria, improve retinal oxygenation, allows direct inspection of the retina, and advance in surgical technique make the vitrectomy result is safer than before. And vitrectomy reduces the severity of the disease and accelerate visual rehabilitations as our patients expected. So to eradicate and control infection, I think we have the same thing to do with other center. We give the local antibiotic like eye drops and also the intravitreal antibiotics, and also giving systemic antibiotic of 4th generation fluoroquinolone. And for managing the inflammations, corticosteroid is still the most potent anti-inflammatory agents, and we can give it systemic, topical, or also intravitreal. And also supportive therapy, like giving the cycloplegic agents, glaucoma medications as needed. And this is our protocol. For severe bacterial infections with fundus obscuring and intact cornea, we give the patient systemic antibiotic and topical antibiotic at the initial presentations, and then doing early vitrectomy with intravitreal antibiotic, and then take the vitreous specimen for the culture, and then continue the systemic and topical antibiotic. After we get the result of culture, and then the antibiotic are adjusted according to sensitivity result. This is the management of our patients. About most of our patients underwent partial vitrectomy and intravitreal antibiotics, and I think this is quite effective because it can reduce the very bad visual acuity from 88% until 50%. So other point to be considered that we use silicone oil control to eradicate and very severe infections, but our problems are if the infections has subsided, the patient have to come again to our center to undergo the evacuations of silicone oil, and of course this is the problem of most of our patients. And in case of post-cataract surgery endophthalmitis, we perform IOL extractions in most cases. And this is also a problem for most of our patients because they have to come again to our center to do the secondary IOL implantations. So as the summary, EVS is still the reference standard in the management of endophthalmitis, but further evidence is needed to refine the EVS findings. And microbial conditions and demographic characteristic of endophthalmitis patients in various countries are not the same. These differences should be taken into considerations in management of endophthalmitis. Thank you.
Thank you very much. So I think this has been a great summary of what we do for for infectious endophthalmitis. A really good example of real-world experiences in combating retinal diseases. Okay, without further ado, may I introduce Dr. Kyoto Ono Mazui, who is one of the leading ophthalmologists in the field of myopia, and she's going to talk to us about the complications of pathologic myopia.
Thank you very much for a great introduction. Most of myopic patients maintain good corrected vision. However, pathologic myopia is a major cause of blindness. According to this review, pathologic myopia was ranked as the second to fifth most common cause of blindness in the white populations, and was the most common cause in the Chinese study as well as in the Japanese study. Then, what causes the blindness in pathologic myopia? There are three major complications: myopic maculopathy, especially neovascularization, myopic traction maculopathy, and glaucoma or myopic optic neuropathy. And the cause of developing the above complications is eye deformity, characterized by posterior staphyloma. Today, I will focus on myopic maculopathy, especially myopic neovascularization and posterior staphyloma. According to the Meta-PM study group, myopic maculopathy is classified into these 5 categories: 0, no maculopathy; 1, tessellated fundus; 2, diffuse atrophy; 3, patchy atrophy; and 4, macular atrophy. Macular atrophy is almost always related to myopic macular neovascularization. Other lesions like cracks and neovascularization, which occur irrespective of the progression of these 5 categories, are considered plus lesions. And based on this study, pathologic myopia is defined as the eyes having myopic megalopathy equal to or more serious than diffuse atrophy, or eyes having posterior cephaloma. So the development of diffuse atrophy is a gateway to a pathologic myopia. Then what are OCT features of each lesion? This is diffuse atrophy. This lesion is characterized by extreme thinning of the choroid. Almost the entire choroid disappears, besides sporadically remaining large choroidal vessels. Diffuse atrophy starts from peripapillary in childhood as peripapillary diffuse atrophy, which later progresses to macular diffuse atrophy. Peripapillary atrophy is characterized by abrupt thinning of the peripapillary choroid. The transition from relatively normal choroid around the fovea to almost absent choroid is sudden. And because it's not generalized thinning, circulatory disturbance may not be a cause. But anyway, although the area is different, both peripapillary diffuse atrophy and macular atrophy are characterized by extreme thinning of the choroid. Then patchy atrophy and macular atrophy, they are both well-defined whitish lesions, but the location is different. Patchy atrophy is seen outside the fovea, and macular atrophy is neovascularization related and fovea centered. OCT showed that both lesions were not simply an atrophy, but were characterized by Bruch's membrane defects. And neovascularization-related macular atrophy showed similar appearance to patchy atrophy, but it develops only after neovascularization. And then in addition, as I mentioned, the location is different. Macular atrophy is always centered on the fovea and expands circumferentially. In contrast, patchy atrophy develops away from the fovea, and even when it enlarges, it does not enlarge in the direction toward the fovea. Among various lesions of myopic megalopathy, neovascularization is the most common cause of the central vision loss in patients with pathologic myopia. It develops in around 10% of patients with pathologic myopia. Anti-VEGF therapies are currently the first-line therapy for this condition, and ranibizumab and aflibercept has now been approved in Japan, and off-label use of bevacizumab or other anti-agents have been used in other countries. However, not all of the patients become happy. In the patients with neovascularization, new vessels itself regresses by treatment. However, neovascularization does not disappear completely, and eventually macular atrophy develops and enlarges around the regressed new vessels, which worsens the vision in a long term. This patient had neovascularization with small hemorrhage at onset, and 4 years after bevacizumab, neovascularization regressed completely, but macular atrophy develops in 4 years, and the vision has declined. So atrophy can be observed clearly in autofluorescence image. And in this patient as well, there is large CNV surrounded by hemorrhage, but the neovascularization itself has responded to the treatment very well and become a tiny pigmented scar in 6 years. But the large macular atrophy develops, and it tends to enlarge, continues to enlarge, and so the vision has declined to 0.08. The next complication is macular retinoschisis, which occurs in 9 to 34% of highly myopic eyes. And natural cause shows that this condition progresses to more serious conditions like macular whole retinal detachment. And this is a classification by Shimada and colleagues, and they classified retinoschisis according to the location and extent of retinoschisis. And this is another classification using wider scan of OCT. And some modified technique of IOP peeling is shown to be useful for this condition, and which is fovea sparing IOM peeling. Usually we remove IOM completely, but we remain the IOM around the fovea to protect the fragile fovea from surgical insult. And in this case, in the bottom left image, high retinoschisis is seen, but with this technique, retinoschisis has gradually resolved in a long term. And finally, we need to remember that glaucoma is one of the most devastating complications of high myopia. But glaucoma is difficult to be diagnosed, sometimes until its advanced stages, because of deformity and tilting of optic disc, and measuring nerve fiber layer thickness as well as ganglion cell layer thickness is difficult. And Humphrey visual field is difficult to interpret because of large conus and myopic maculopathy. And severe deformity is seen in the optic disc in pathologic myopia. The optic disc is no longer circular or oval, very severely deformed. So I'm going to show you this patient. This is a 35-year-old man. Axial length is 30 millimeters, and IOP is almost always low. And this patient has complained of vision decrease, but he has diffuse atrophy, and he has been told that his vision decrease is because of myopic maculopathy. But when he came to our hospital, his visual field is already like this, and IOP is low. And sooner or later, we performed surgery, but in 5 years or so, he completely lost the vision. And glaucoma is overlooked and underdiagnosed in pathologic myopia, even until its advanced terminal stage. But because it develops at a much younger age than non-highly myopic glaucoma, and it is not rare for them to completely lose sight during productive years. So we should advocate always suspect a glaucoma in highly myopic patients. So in conclusion, pathologic myopia is defined as eyes having myopic maculopathy equal to or more serious than diffuse atrophy or having staphylomas. Endovisual therapy and vitrectomy are effective to treat neovascularization and retinoschisis. And glaucoma is common and progressive. However, it's overlooked and underdiagnosed in pathologic myopia. So we use Goldman perimetry regularly. Staphloma is well observed in wide field OCT, and future therapies would be to prevent the progression of staphloma before developing vision-threatening complications. Thank you very much.
Thank you for this enlightening talk. We have many questions, but we'll keep it till the end. So next we have, since Dr. Ellie Pradhan has already given her talk in the beginning of the session, we have two talks left, and in fact, we're doing quite well for time. So thank you for keeping to the time limit so far. So may we introduce the next speaker, Dr. Praveen Sen from India, who's going to talk to us about multimodal imaging and AMD. So also a little bit related to the previous speaker as well with the multimodal imaging. So thank you.
Can I have my slides, please? Yeah, thank you. So I thank the APAO and AIOS for this excellent session and the few talks that I've heard till now. I think all women, we must congratulate. They are the best in their field amongst ophthalmologists, and not only just women in ophthalmology. So without any further delay in time, I will talk about age-related macular degeneration and how imaging and multimodal imaging has brought a sea change in not only how we treat our patients, but how also we understand this disease. So AMD, as we knew it, this is what we always grew up with. This is the AREDS classification of early AMD, which is characterized by drusen and RP abnormalities. Intermediate, if the drusen size is more, and late and advanced, the only thing we knew was wet AMD with a CNV or a dry AMD with geographical atrophy. But now, There are almost 38 different types of drusen which are described, and they can coexist in a single patient. There can be small size, large size, reticular, cuticle, hard drusen, soft drusen, distinct, indistinct. And out of these different types, the one which stands out is the subretinal drusenoid deposits, or the SDD, and they are no longer known to be only sub-RPE, but they sit on the RPE, and they have a whole different kind of disease pathology. They are more associated with thin choroids, more associated with older age group, more associated with type 3 MNV, and more associated with geographical atrophy. So this just the kind of drusen, and you have the whole way that we treat our patients can be different. And they can coexist with two different types of drusen. So this is what I spoke about, MNV, which is found to be a type 3 or a RAP lesion, which is more common in patients who have SDD. And so we know that the progression of disease, this was the basic AREDS model, that first you will have soft drusen, and then they cause focal hyperpigmentation, and then they grow into either a CNV or a geographical atrophy. But now we know that you may have soft drusen, and they can be large or intermediate, or they could be SDD. They grow into focal hyperpigmentation, but they can progress to GA or neovascularization without going into RP atrophy changes. And we also have another thing called the pachydrusen, which are large drusen which can be associated with thick choroid and associated with polypoidal choroidal vasculopathy, which forms almost 50 to 60% of our patients in the Asian population. So new classification system, the Conan classification understands that these are no longer always choroidal in origin. These neovascularizations can have macular origin, so especially the type 3 one. So we no longer call them choroidal neovascular membranes, we call them macular neovascularization. So the terminology itself has changed. It is MNV and not CNV anymore. So this is just to show how the type 1, which is sub-RPE, type 2, which goes beyond the RPE, and the type 3, which actually originates in the inner retina and then grows downward. And the hypothesis for this kind of retinal neovascularization is also understood from the imaging modalities, and which is that we know now that these are the short ciliary processes which intersect at the macula and cause an ischemic area there. And because of this ischemic area, which is more so present in temporal to fovea, there is a watershed zone, and this ischemia is responsible for retinal neovascularization, which sets in leading to type 3 MNV. So this is what the hypothesis for type 3 MNV is: aging, thin choroid, hypoxic area, increase in HIF, increase in VEGF, and this VEGF concentration in type 3 MNV is higher as compared to type 1 and type 2, and which is why probably type 3 MNV, if you diagnose, the clinical implication is that they respond very well to anti-VEGF therapy. And these hypoxic areas are very well imaged as well by choriocapillaries flow deficits, and they are related to risk of progression to geographic AMD, and they increase by about 11% if you see, and more of this CCFT is present surrounding CNV areas rather than dry AMD also. Not only this, it has been shown that it is the rod cells which are more responsible for hypoxia, and so you may have associated night vision problems in patients with type 3 MNV. So now, where the neovascularization is concerned, there's a sea change, and there's a sea change where geographic atrophy is also concerned. We have always seen geographic atrophy based on fundus autofluorescence, but OCT has been the game changer, where we have recognized that you can have geographic atrophy without involving the RPE. So you have a full thickness or a complete or C-RORA, where both RPE and outer retinal atrophy is there, or RORA, where only the outer retinal atrophy is there. And this has been shown now in the CAMS classification atrophy report 3. You can see it is divided into 4 types: the C-RORA, the I-RORA, the C-ORA, and I-ORA, depending upon whether the RPE or both the RPE and outer retina is involved in the atrophy. And the risk factors are also seen, which is very clearly we can prognosticate these patients, we can tell them how soon your progression can be. So because of the change in nomenclature, we now understand that PCV is type 1 neovascularization, and we call it the polypoidal lesion as well as the BNN. And we don't need to rely upon ICG at all for diagnosing PCV, because now OCT is being used as a gold standard, and there's a major shift to non-invasive form of imaging modalities which can give us the proper diagnosis, and we can treat our patients accordingly. So this is the APOIS PCV work group, which has given us the non-ICGA treatment criteria, which is the sub-RP, ring-like lesion, sharp-peaked PED, and orange nodule. And this put together can help you diagnose PCV with a specificity of almost 80 to 90% in our cases. And even you can treat it, you can map the area on in fast OCT picture, and you need not have ICG to give you the GLD for doing PDT. So definite shift to non-invasive imaging treatment investigation modalities. And also this picture. So what we have also always known that pachychoroid is responsible for the whole spectrum of PCV as well as CSE. Now we know that it is the peripheral vortex congestion which must be the root cause for all this. For all you know, what we have now been treating medically may end up having a surgical cause, and if we sort of decongest the vortex veins, maybe that may give us the answer. So anastomosis between the superior and inferior vena cava, inferior vortex veins is known to be present in 90% of pachychoroid disease spectrum cases. And if this is the horizontal meridian which is involved in the anastomosis, this gives rise to PCV and CSE, while if it is a vertical meridian, it gives rise to peripapillary pachychoroid spectrum. So how does MMI help you in the decision making and management? First of all, it helps you diagnose whether it is AMD at all. There are other lesions in the fovea, like a yellow spot or a vitelliform lesion. This may mimic AMD, but this is not really AMD. This is nothing but adult onset vitelliform disease. You can have these vitelliform deposits in patients with AMD as well, but a keen look at the OCT will show you that there is no associated subretinal fluid or IRC, so these can be safely watched. So to determine whether the disease activity is present at baseline and how would you follow up these patients, we have all sorts of fluids. This was not possible before, but now we can compartmentalize the fluid into intraretinal, subretinal, sub-RP, and when to start treatment. We all know that you could have now non-exudative CNV as well. So if you see a CNV which is present, but there is no associated fluid, you can watch this safely and follow it up by excellent multimodal imaging techniques, including OCT angiogram, which can show you that even if there is a small increase in the size of this network, you can measure it and gauge it and start treatment accordingly. So this is how you can follow up these kind of cases. You can classify them, as I described, into types of neovascularization. This is important because the response of therapy to a type 2 MNV would be different from that in type 1. As I said, the type 3 responds very well, type 2 will respond well to anti-VEGF, type 1 will need multiple injections. So you can prognosticate cases, you can explain to your patient based upon this kind of OCT angiogram findings. So assessing response. For assessment whether your therapy is working or not, we again have these criteria, OCT biomarkers, which can tell you whether there is a decrease in fluid, decrease in cyst, decrease in height of PED, decrease in the sub-RPE hyperreflectivity or hyperreflectivity. All these things help you gauge whether your treatment is working or not. And when to stop treatment, again, $1 million question. This can also be based on your exit therapy, can be based on OCT and OCT angio. You could give specifically if you have extended the treatment for nearly 16 weeks for 3 consecutive times. If you can consider exit, you can very closely follow these patients on multimodal technique and give them a treatment pause. So imaging in AMD can see more than what meets your eye or my eye, and imaging can be like your best friend holding your hand throughout the journey of treatment for our patients. And with AI, imaging can become much more powerful than we know it today. but I think I would like to still finish. It's just like fire, good slave, but a bad master. Key is always clinical correlation, and there is no substitute for clinical acumen of for our patients. So thank you very much for the patient hearing.
Thank you so much for introducing me to this new classification or nomenclature of macula and neovascularization. Now I can finally talk to my retina colleagues in a more educated way. So may we introduce the last speaker of this session. So Dr. Ganeshan, who's going to talk about masquerade syndromes. We're doing quite well for time, so no need to rush to. Yeah.
So I would like to, begin with this slide. When we say it's on a lighter model, so you see two images. So can anybody guess what is each animal here? So one is a lion, the other one I will allow you to keep guessing. So with that, a warm good afternoon to all of you here, and I would like to thank the AIOS and the APAO and the WAS for giving me an opportunity. So I'm going to be talking about unmasking the masquerade syndromes. So a little bit, my topic's a little deviation from what the other speakers spoke. So here is a lady who is a 17-year-old young girl with 6/24 vision. She comes with pyrexia of unknown origin. So you can see here, she has a lot of exudates in the vitreous. So when you see such a patient who comes to you with fever, so what would be your first line of thinking? So we all tend to think so much of exudation, and you can see the ultrasound, what is happening. So with a fever which is there for at least 12 days, so your thought process is, am I dealing with an endophthalmitis? That would be the first line of thinking. So what did this girl have? This girl, when I did the vitreous, so of course, before that, I had already worked up this patient because I'm an oncologist, so my line of thinking would be a little different from the other way of approaching. So I knew very well what I'm dealing with. So what was she having? She was having an immunohistochemistry that is positive for a neuron-specific enolase, and she also had the retinoblastoma protein positive, the synaptophysin positive. So what was negative? It was the HMB that was negative. And of course, so when we know now what we are dealing with, this condition is an adolescent onset retinoblastoma. So when you see an eye that is quiet, and though there is a history of fever, do not get carried away. And if your ultrasound is not revealing calcium, not all the time you may get on that also. So this is something which you should keep in mind. Now, in the literature, how many cases do we have? So basically, if you see, not more than 30 cases are there till date on adolescent onset retinoblastoma. So next is a 26-year-old male patient who comes to you with 1/60 vision in intraocular pressure of 16 millimeter of mercury. The blurred vision is for 4 months, and when you can see on the picture here, you can see a pigmented mass that is there with a detachment in the eye. So when we did her MRI of this particular patient, so what it did show, it was low signal on 2 weighted images and a post-contrast enhancement was homogeneous. So the suspicion is high on a melanoma. So now with a melanoma, the usual practice for these kind of patients are what? Because the size is 11.5 millimeters. So then you tend to think, okay, now I'm having a melanoma. The options for these patients would be to give what? To give either a proton beam therapy or to give a plaque brachytherapy. So what did I do instead? So I thought, because from the ultrasound, to me, it did not look like the melanoma, so I decided to resect the tumor. So what was inside? So this was a patient who is having a whitish lesion. So it was pigmented on the outside, but when you see inside, this is a white colored mass. So what is this? This is called as, now when you go through the immunohistochemistry, and of course when you see the lesion, which is white in color, pigmented only on the surface, so this is a leiomyoma. So leiomyoma, which is supposed supposed to be desmin positive, the vimentin positive, calponin positive. So here is the confirmation that it is there. And when you see on the histopathology, it is a lower nuclear cytoplasmic ratio. So when the NCA ratio is very less, you know you're not dealing with any malignancy. So now, what is a leiomyoma? It is a smooth muscle tumor of the uveal tract, predilection to females, and it affects the ciliary body and the peripheral choroid. So the treatment is endoresection or the sclerouvectomy. So it's not life-threatening. So this patient was referred for the management of melanoma when the whole family was like sinking in the thought that they're going to be having a tumor. But then, yeah, giving the diagnosis that no, you're not going to be dying, rather you're going to be living more than anybody else, is something which you are going to be giving. So what is the difference between a leiomyoma and a melanoma? Leiomyoma occurs in the supraciliary or the suprachoroidal space, whereas a melanoma is coming from the uveal stroma. And the most brilliant clue is the transillumination. So if you can pick up the transillumination, you can hit on the diagnosis of a leiomyoma very well. So moving on to the next patient, she's a 65-year-old female with a vision of hand movements, intraocular pressure being normal, yet again a pigmented mass lesion. So the current thought process is what? It is like hyper on T1, hypo on T2. So very characteristic, even on an ultrasound, if you see the surface reflectivity and the internal reflectivity, you can almost think, yeah, it's very solid, so possibility of a melanoma is very high. But then what exactly is it? When we did the tumor biopsy of this particular patient, it revealed plasmacytoid cells. So the plasmacytoid cells, what does it account to? So we did the hematological workup. So the CRAP criteria is to be followed, because when you deal with plasmacytoid cells, so your thought process should be in terms of a multiple myeloma. So here you do all the CRAP workup and the biomarkers. And then what do you see here? This patient belonged to what is called as the solitary plasmacytoma, which is only present in 7% of the individual. But very commonly when you tend to see a plasmacytoma, extramedullary plasmacytoma, be very vigilant, run a good workup for the multiple myeloma, because these clonal proliferations, tend to get differentiated. So the treatment for these kind of patients are like to give a radiation therapy. So when I gave a cyberknife therapy, because did not want to go into the IMRT, because that could be more toxic in these patients, and these are not very aggressive forms, so cyberknife is more sufficient. So here is a 25-year-old female, 6/18 vision. Again, the MRI is hypo on T1 and T2, referred as melanoma with, of course, the exudative retinal detachment, which is there. The height of the tumor is more than the base, fitting into perfectly a melanoma. But what is it? When you do the biopsy, it turns out to be melanocytoma. So melanocytoma is again not aggressive disease. It is a benign lesion. So a patient would never die of a melanocytoma. So the crucial role is, once it's very important, that not all pigmented lesions are melanoma. That is what is a common myth people tend to think. So now, I did a biopsy of this patient, of course, settled the retina also. You can see the pigment dispersion, because she was a girl from Ethiopia. So you can see a lot of, in these pigmented rays, the dispersion will be very high, So this is 3 years later. She was 6'9", N/6, with no subretinal fluid even at 3 years. So she was a PhD student, and was going to be married. And the mother was almost in tears when she came all the way from Ethiopia to India, and thinking that her daughter would die because the diagnosis was a melanoma. Then we broke the news that, no, it's not a melanoma, it's a melanocytoma, so it's not going to be any life-threatening disease. Now we move on into a 5-year-old female who is 6/18 N6 vision, and you can see the tiny little thing on the infratemporal border of the eye. So this is the root of iris invasion, and you also see what is happening from the ciliary body. So this is a ciliochoroidal lesion. So yet again with a base of 11 millimeters and a height of 11 millimeters, hyper on T1 and hypo on T2. So this yet again on your MRI would be reported as melanoma. So when these kind of things come, that is because of the solidarity of the tumors. On bleach preparation, you tend to see the epithelioid cells. So this is one more thing of not a melanoma, a melanocytoma. So this is another patient who just came in with a PL positive vision with projection, of course, deficient in 2 quadrants. She had renal cell carcinoma. So this was referred to me as a metastasis, choroidal metastasis. So yes, this was the picture which we saw on ultrasound, a very globular lesion anteriorly located. So when, of course, when we did the MRI and the whole body PET CT scan, there was nothing else apart from what is the involvement in the eye, intermediate signal on T1 and hypo on T2. So this again was diagnosed as a choroidal metastasis. So what did we see? We saw a leiomyoma which was inside. So now your whole staging differs when you have a patient who's got a renal cell carcinoma with a choroidal mets. So obviously the treatment pattern is different. But when you do the biopsy and you prove that it is not anything connected with that cell carcinoma itself, and local resection has worked, and this is a benign lesion which is sitting in the eye. So this, you should never get carried away by when a patient gives you a history of carcinoma and then connect it with what is in the eye rather than proving without a histopathology. So this is a 48-year-old female, again with flashes of light, 6x6 and 6 with history of rheumatic fever, and of course on penicillin prophylaxis. So now what is the diagnosis from here? Now that I've shown so many pigmented lesions, so what do you think this should be? Is it benign or malignant? So I did a brachytherapy. This is pre-brachytherapy. And then a month later, 7 months later. So you see, this lesion did not respond. It's consistently growing. What do you see here? So this is a melanoma. So this was quite in the beginning of my career when my understanding on the biopsy was not there great. So what did the patient go through? A mixed cell melanoma, extensive necrosis, episcleral extension, monosomy positive, orbital accentration had to be done to save this patient. So all pigmented lesions need not be melanoma, but a melanoma should never be missed either. So what are the differentials when you have pigmented lesions? Melanoma, metastatic tumors, nevus, neurofibroma, schwannoma, hemangiopericytoma, choroidal meningioma, adenoma of the ciliary epithelium, medulloepithelioma, medullocytoma, so melanocytoma. So all these things are something that is to be kept in mind when we see these lesions. So the simple message to carry is MRI is not the diagnostic modality in pigmented lesions of the choroid. Tissue biopsy is mandatory. Adequate sample is necessary. Otherwise, when you just send a few samples to the histopathologist, he will say that he will give you a report stating that inconclusive. So when it comes inconclusive, you are in middle of nowhere. Histopathology is again to be supported by immunohistochemistry. Comorbid conditions may arise later. Systemic surveillance is of utmost importance. That is the key buzzword here. So now the answer to the question of what is the other animal that was there, which is not a lion, so it is a Tibetan Mastiff. So with that, I would thank the audience for giving me an opportunity to share my thought process here, and I thank my colleagues in my institute who have been supportive to, in referring the patients to me on time and having belief in me that I can do the job. Thank you.
Thank you so much, and all the speakers have kept to time very well. So now we have about 10 minutes for questions. So do we have any questions from the floor? Any questions? So
very interesting topic. There must be some question. Anybody?
I think if no one from the floor yet, may I ask the first question? So maybe just following from Dr. Ganeshan's talk, this is quite a. These are quite rare tumors and very scary for us, for most of us. Do you now biopsy all of these lesions, or do you only pick some of them? Because you mentioned that you biopsy the pigmented lesions. What about the non-pigmented lesions, which you suspect are metastases?
My talk simple, I had put down all the pigmented lesions together. Of course, the lesions that are not pigmented, that are even more challenging because it will be amelanotic lesions. So amelanotic lesions also, see, like you must differentiate between whether you're dealing with an infection, whether you're dealing with an inflammation, or whether you're dealing with a neoplasia. So these are the three categories under which you would like to categorize your patient. But if you are like in a country like India where the tuberculosis is very predominant, so that would stand up on the line of treatment first. So before we do a biopsy, all these patients do a complete whole body screening. So we kind of rule out whether are we dealing with infection, which infection means the first thing would be tuberculosis. So if anything coming from the choroid, are we having a granuloma, whether it is a tuberculous granuloma, whether it is a sarcoid granuloma when it comes to amelanotic lesions, or it is an amelanotic melanoma. So this is also there. So first would be a full body screening. Once we know that we are not having any other clues to the diagnosis, that is when the biopsy is attempted. But when I have high on suspicion, even if it is a melanoma, even before I do the brachytherapy, I do take the sample for biopsy. That the reason for biopsy becomes different. One is you would like to understand whether you're dealing with a type 1 melanoma or a type 2 melanoma, because yet again you have to tell your patient that it is malignant, but how is the systemic surveillance going to be? So if it is not the aggressive form of melanoma, because in India the aggressive form of melanoma is very less. So the Western countries, the non-aggressive is very less, aggressive is more for them. So their death due to melanoma is more than our deaths due to melanoma. So when you have to talk to your patient, they always look at, I'm having a cancer, am I going to live for long or no? That answer is something which you should give. So because of that reasons, I do the biopsy and then I classify it, and then if we have to break the good news, they're more than happy, or if we have to break the bad news, that how are we going to keep them on follow-up. So in that situations we always tell them. So for that reason, yet again biopsy is very helpful. But in granulomas, not all the time biopsy is required. So in these things, what is the most important thing is the ultrasound should be done by yourself. So that is most important. You do the ultrasound, and then your MRI person has to be really good in understanding that, and they should tell you how they see the reflectivity on the MRI. So yeah, but not all patients I do a biopsy. The workup has to be done completely. That is most important before we err on the side of doing the biopsy.
What type of biopsy you prefer?
See, there are two ways of doing a biopsy. You could, if they are peripheral tumors, I would do a transscleral biopsy. If it is a tumor that is posterior, then the transvitreal approach is being done. But along with it, if I feel it's a malignant one, then I do the resection, endoresection also. Yeah, so endoresection for the benign ones, and if I am having a malignant tumor, then I do sandwich therapy, in the sense that you do a pre-radiated, then you do the resection, then post-radiated. So like that we follow a sandwich regime of treatment. If the patient is not willing for a proton beam therapy for cost reasons, proton beam becomes very costly, but that's still available in Chennai, so it's not a big issue, but yes. An aggressive form of tumors, we do that.
Right. You mentioned whole body screening. Would you do PET CT or and all the blood tests? Or?
Yeah, so along with the blood test panel of investigations, I would do a whole body PET CT, whether that is, if you're thinking in terms of an infection thing, then that panel is different from the malignant panel. So right. Either one, whichever you feel that is high on your priority, you would advise that.
Great. I think we have to send a fellow for overseas training to Sankara and Nataralia.
You want to ask question?
I had a question regarding pathological myopia, Jamal.
Oh.
The first one is you showed a case where, despite being on regular anti-VEGF therapy, the patient went for macular atrophy. So was that was a part of the natural course of disease, right? Like, irrespective of whether you gave anti-VEGF or not, there's nothing we can do, or is there any correlation?
Yeah, thank you so much. Yes, macular atrophy develops in natural course as well. And anti-VEGF therapy shrinks, makes the neovascularization shrink. So the virus, the size of macular atrophy is relatively smaller than the natural course. But the anti-VEGF therapy makes the shrinkage suddenly and greatly. So when neovascularization shrinks significantly, surrounding chorial capillaries makes a gap and break, and it may trigger some parts of macular atrophy. So anti-VEGF is great, but it is also possible to trigger chorial capillaries damage because of acute shrinkage.
And ma'am, another question was regarding glaucoma and pathological myopia. You've told how like visual fields won't help, RNFL won't help.
Yeah.
So how do we really suspect in early stages?
Yes, actually, early stage of glaucoma is difficult to determine, but here, even terminal ones are overlooked. It's a problem. So we usually perform Goldman perimetry, and we just look at the outermost eye sophta, because this eye sophta is not affected by maculopathy or conus. So if this is full, wide enough, it is basically okay. And so, but in many patients, this eye sophta is affected. So just, it's an easy way.
Thanks.
Thank you.
Any more question? Gita. Okay.
I want to ask to you, Dr. Ganesan. I'm just very excited that you do examinations to the last cases of melanoma cases. So I want to ask you, is it enough to decide we have to do the examinations just from the biopsy, or we have to do the other examinations for knowing the staging of the disease? So what kind of examination you do before decided to do the examinations? Thank you.
The first thing I would like to tell is this particular patient whom exenteration was done was a patient who was treated by my colleague when we never used to do biopsy in those patients. So that patient kind of progressed, so most important thing is when we do a brachytherapy, what you should do is you should know whether your patient is responding to the brachytherapy that was being done. And when you do a brachytherapy, it is like, depends on what kind of isotope that you have used. So if you have used an isotope which is going to give you a margin coverage well of around 2 millimeter from your mass lesion, then you can be rest assured that it is going to work well. For some reason, if you've used a brachytherapy, like for instance, what we call as the borderline tumors. See, there are something like medium size and large size. So the large size melanomas are always better treated with iodine plaques. But in iodine is not available, iodine 125 is not available in many centers. But yeah, fortunately in my center we have iodine as well, and we do have ruthenium also. Both these things are available. So when somebody has done a ruthenium on a borderline, that is when you get into these kind of problems, because these are borderline. And if you have not treated, so what happens is, see, all these isotopes which we have, like whether it is ruthenium or iodine, if your height of the tumor is not completely covered by the radiation, you may have remaining viable cells which will keep growing also. So that is something which you should pick up very early. Like for instance, after your brachytherapy, your follow-up has to be very stringent. You don't have to follow immediately, month-wise, no. The 6 months is most crucial. At 6th month, if your patient did not respond well, then you must understand that there is no fluid reduction and the mass height is not maintaining the same. Then you should know that this patient is not something who is responded to the treatment. So in that condition, what you must do is again replaque it. You can do that, or the other option is to go ahead with the enucleation. If for some reason at that point the patient is not willing, they would like to have an eye salvage being done, then it becomes a problem. That is when all the problem starts, like the delay over there. Because once there is a delay, this is in the choroid, so it starts metastasizing also. And the first site of metastasis would be to the liver. And once it goes into the liver, it is very difficult to keep the patient alive. But yeah, now of course things are little better, because this particular case was something that happened 5 years ago. But now it is, they do lobectomy, they have targeted therapies, which were not available 5 years back. Now you have immunotherapy, you have targeted therapies. So all these things can be done if your patient is positive for one of those. But at that point we did not have. So the only way to survive, keep the patient surviving, was now to excentrate. So excentrate means they remove it completely. There's no lid, there's nothing over there, they excise it from the bone. So that is what is being done, because after enucleation also we still had the choroid completely involved and it was still spreading. So that's when the decision was made to excentrate. But had it been now, I don't think we would have allowed this scene to happen at all, because we are more prepared and we understand the disease very well, how it is going to progress. So our reports are basically available, like in our institute, all the protocols which we do, the mid-88 and all those things, they are available within 2 working days. So there is no delay. The moment I do the biopsy, within 2 working days, we get all the reports, the immunohistochemistry, the mid-88. So you have a working algorithm that is already being made, that whether this is class 1, this is class 2, aggressive, non-aggressive, how are we going to deal with. Then we have the dialogue about, are we going to radiate this patient, or are we going to adopt any other resection modalities, or going to sandwich both together. So all these things are there, and the yet another plan is also ready. Like if the patient is not going to wanting to take the hassle of whole lot of things, they might go ahead with the enucleation also, with the systemic survival. That is still happening. So the option is given to patient completely. So the
one
family
simple
takes the
thing.
decision.
One thing. Before giving brachytherapy, do you measure the size of the mass?
Yes.
How much? What is the size of the mass when you advise to give brachytherapy?
So brachytherapy is given for lesions that are medium and large size melanomas. And of course the small size, nowadays we get patients even with the small melanomas also, where one can do transpupillary thermotherapy. So we don't really have to radiate those small melanomas, and because now because of the availability of OCT and awareness that is being there, so patients do come very early. Initially we were not seeing small melanomas that much, to the point that to differentiate between a choroidal nevus from a melanoma, now that has become the point of focus, to see where are we dealing, because you can, when the tumor size is very small, it's very difficult to differentiate, are we dealing with a nevus or are we dealing with a melanoma. So that is when the criteria which the Shields have proposed, TFSOM, comes into play, whether to diagnose this as a nevus or a melanoma. And if that is the situation, a TTT is being done. And these small melanomas do not have the dual circulation, which starts coming on later in the stage of the disease. When it comes to the medium sized melanoma, then the dual circulation starts coming. So in FFA, you will be able to see the double circulation. Until then, you will not be able to see. So for a medium sized melanoma, you could either do a plaque brachytherapy, which can be ruthenium, or you can do a proton beam therapy if that is available in your country. These are the 2 modalities which is being done. In certain families, if they don't want to keep coming for follow-ups because they feel that coming regularly may be painful, they go ahead for enucleation also, because it is a malignant tumor anyways. And the third thing is the large melanomas. The large melanomas go only for brachytherapy or for enucleation.
Okay, thank you very much. As because next session will be there, so I would like to thanks everyone, as because everybody's presentation is very good, excellent one, and if we can continue that discussion, that will be much more better. But we have no time.
Okay, thank you so much.
Thank you.